Mal and Dr. Nicholas, thank you very much for having me here to speak today. It's a special honor for me because Dr. Nicholas hired me, Dr. Jim Nicholas, for my first job at a PT school, my first real job at a PT school. We spent about 2.5 hours in that first interview. It was quite a session. He was a tremendous human being and has influenced the direction of my career and still does today. So I'm forever in debt to my relationship with Dr. Jim Nicholas. So I've been asked to speak about return to sport after microdiscectomy, and the literature is flooded with information that both looks at non-operative as well as post-operative, so we'll have some information scattered throughout. So we'll start off by looking at some sports analyses, various meta-analyses looking at individual sports, pro athletes, all levels. We'll look at some of the pitfalls that our athletes fall into in trying to get back to their sport. And then we'll look at some of the rehab principles that are so important to most of the people in this room in getting our patients back. So looking at some meta-analyses, most recently Reinman reported an 84% return to play rate. All sports, all levels of play. The time frame was about 5 to 9 months. Return to sport means they return for one game. So if they return for one game and retire, that's a successful return to sport stat. So it's not the greatest indication of how well they do. We've heard a lot about that today. What do these stats actually mean? Diving deeper in, 59% actually returned at the same level of sport. Career longevity was 4 to 5 years in this study, and Overlay did the similar study looking at just post-surgery, similar results, 84% return to play, regardless of whether the athletes had surgery or were treated non-operatively. Wellington Sue was involved in almost all the meta-analyses that look at athletes and return to play after surgery for the lower back. So his study of he looked at 342 pro athletes, NFL, NBA, MLB, and NHL, with 2-year follow-up. He reported an 82% return to play regardless of whether they had surgery or not. At 2 years after time of injury or surgery, only 62% were playing. He also reported that age was a negative predictor to longevity, career longevity, and return to play. Experience, the number of games that you had under your belt at the time of injury or surgery, was a positive predictor, the more likely you were to return to play. Career longevity was about 3.5 years across all sports, so we actually normalized them because baseball, as Mike talked about before, baseball has a time frame, a career length close to 7 years, and football is about 3.5 years. So when you normalize across the sports, it's about a 3.5, no difference between the different sports. Baseball is a unique animal. So Earhart looked at Major League Baseball, 69 cases of disc herniations treated either surgically or non-surgically. Only one athlete from each group did not return to play. So that's the highest return to play rate of all the sports. The difference between these two groups, the non-operative group returned significantly faster, 14.5 weeks versus 35 weeks. So almost 9 months in the operative group to return to play. That's some of the longer time frames. Of note in this study, those that had surgery had shorter careers. It's the only study, the only sport that is shown in. NBA players have a 75% return to play rate with no decrease in performance, whereas NHL players have an 85% return to play rate regardless of whether they have surgery or not, but they do have diminished performance after injury or surgery. And we'll look at some of the reasons that might be in a second. Of note in this study, 8 fusions all returned to play. So hockey is a unique animal. It's got high rotation and shear forces across the lumbar spine. It's the number 4 reason lower back pain for missed games. Those rotational forces we're talking about are usually in a forward flex position with the one-timer or slap shot. And the wide grip that the athlete has on the stick forces more motion, more movement through the lumbosacral spine. Combine this with the high incidence, as Tim was talking about, of FAI and sports hernias in our skaters, and now you really have a cluster of reasons why hockey players may have a harder time returning to sport after a lumbar injury, a disc injury, very high stress across the disc. So return to play after surgery in the NFL is about 75%. Delving into a few of the studies, if you show up to the combine, the NFL combine, and you have a history of back pain, you are less likely to be chosen to go on to the draft. However, those that actually do get drafted and play that have a history of back pain do not have a decreased level of performance, and they do not have a shortened career. So that's really without good reasoning, except for two cases, two incidences. One is if the athlete had spondylolysis or listhesis, and one is if they were a defensive back with lower back pain. Those two do have shortened careers. And if we look at linemen, Weistroffer did a study looking at 66 NFL linemen. 52 were operated with an 80% return to play rate. That's about right. 14 non-op with a 29% return to play rate. That's not right. So something's wrong with that number. It's the only study, the only sport that showed a significant difference between return to play rate in the non-op group. So if you dive into the numbers, the operative group were 27 years old. The non-operative group were 30 years old. It's a significant difference. The non-operative group were closer to retirement at age, so it likely affected their decision on whether they were going to have surgery or not. In the surgical group, there was a 13% re-op rate in the linemen. 13% is fairly high, but after they had their second surgery, they had an 85% return to play, which is very good, actually. It's a very high success rate. Of note, 6 of the 7 of these linemen were offensive linemen. So there's something about what offensive linemen have to do in their job that makes them more vulnerable or more difficult to return after surgery. So let's look at some of the rehab studies that look at exercise and general rehab programs versus control groups in return to in getting our post-operative patients back in the game. They're not very good, even just getting them back to work, right? So long-term difference, no significant difference. Some benefits in the short term. 2 take-home messages. 1, early rehab is better than late rehab, and high-intensity rehab is better than low-intensity rehab. So if we have such high return to play rates, and the evidence is not great for what we do in general, why rehab? Well, the answer is in a few of these studies that show over a 2-year time frame and beyond, there's studies out there that point to diminished outcomes over time. Okay, so at the level of surgery, degenerative disc change is starting to set in. And some of the studies are showing that it is associated with the degree of or the aggressiveness of the work we do or the surgeon does at the annulus. So the more aggressive they have to be to go in and remove the disc material, the more likely they may have degenerative changes down the road. So we have to keep this in mind as we're rehabbing our athletes. Up to 25% are having worsening pain and disability over 2 years, despite doing well early on. The reherniation rate in the literature, if you read it, it's anywhere from 3 to 7%, but the reality is, if you read this study by Lebeau, which was an excellent study, 108 post-microdiscectomies followed every 3 months for 2 years, MRIs and CAT scans. There's actually a 23% reherniation rate. The symptomatic group is only 10%. There's more asymptomatics. There's more silent reherniations out there than there are symptomatic. Of note in this study, there were no degenerative disc changes throughout the MRI studies. So why do our patients get postoperative pain? So we'll start talking about some of the gaps in what I believe may be in the athlete's development, in their movement patterns, and what goes wrong after surgery and after injury. So here's what we know. We know from ultrasound studies that the multifidus muscles, which are very important to stability of the spine, have atrophy. We also know from MRI studies that there's fatty infiltration at the multifidus level, the multifidus muscle. And this fatty infiltration occurs in lower back pain. It's been shown in postural dysfunction and has definitely been shown post-surgery. What do we know about fatty infiltration from the shoulder research, which is really where we get most of our information from on fatty infiltration or early studies? Fatty infiltration leads to poor outcomes, and it's thought to be irreversible with surgery. So hopefully that's not the same in the lower back, and as research comes about going forward, we may see some changes in that, I hope. This was a great study. It's a Scandinavian study, almost 1,000 subjects. So general population, 412 40-year-olds and 442 adolescents, all got MRI'd. And what they were looking for was an association between history of back pain and fatty infiltration in the muscle across age groups. And there was a strong association with fatty infiltration if you had back pain within the last year. There was a much stronger association if you had chronic back pain, if you've had back pain ever, if you answer the question, have I ever had back pain ever? Yes, and having fatty infiltration. If you are a woman with a history of back pain, that incidence goes up even higher. So there's clearly something going on. There's morphologic changes going on in people that have back pain. And after surgery, this study by Tarabe, 24 microdiscectomies were MRI'd before surgery and 6 months after. And only 6 months after surgery, we see a 17% increase in fatty infiltration of the multifidus muscle. Now, the fatty infiltration and the atrophy is localized. It's segmented. It's segmental. It happens at the level of surgery and 1 or 2 levels below, and it's ipsilateral. It's on the same side. So something's going on here, denervation. It's not just disuse. We also know from this study by Lon that preoperative myotomal weakness will have an effect on our outcome. And this is a big question I get from my patients. I have foot drop, I have weakness in my hamstring, I have weakness in my calf. Will it go away after surgery? So this study is one of the few that are out there that actually have tried to address this question. And it showed that you have a 4-time increased likelihood of a poor outcome if you are in the severe category of preoperative myotomal weakness. So it doesn't matter how long you had the preoperative myotomal weakness, but the severity is a very important risk factor for a poor outcome. So what are we to do? One, we know that back training, back strengthening exercises are effective. They improve back strength, extensor strength significantly. We get significant improvements in function and pain, and there's some evidence that we can improve the morphology of the muscle. We know we can improve the atrophy. Can we improve the fatty infiltration? We think so to some degree. What's even better is when you target the problematic areas. So if you gear your therapy, if you gear your rehab program to the multifidus that is inhibited, to the transverse abdominis that's not firing properly, and to the glutes and the other muscles around the system, and getting them coordinated, you have a much better chance of success in your patients after surgery. So here's what we know. We know that lumbar microdiscectomy has a high success rate when non-operative treatment fails. Okay, that's a given. We learned that from the sports study, and we learned that from multiple studies. Rehab works when it's done early, when it's done with intensity, and when it's focused. So let's talk about our rehab. So I'm going to spend most of my time, because I'm a therapist, and I have the patient probably for 6 to 8 weeks in a high-level athlete before they start going back and working with their trainers, before they go back working with their teams, or before I lose them to go back to college and play at college. So this is my time frame to get them and start putting them on the right track and discover where some of the problems lie. What were they missing in their kinematic chain early on, and start breaking that down so we can get them back to sport safely, more safely. So first, we spent a lot of time on transverse abdominis activation. The stabilizer is a wonderful device. We used to spend, before this thing came on the market, we used to put our hands under the patient's lower back all day long and just have them squash our knuckles and try to compress using a transverse abdominis, creating a neutral spine. So this takes all the guesswork out of that. It gives them an exact idea of how well they're contracting, how well they're controlling. The needle moves as they lose control. It's fantastic feedback. We give them to the patients they take home. You can rent them to the patients. You can sell them to the patients. They're under $100 bucks. They're a great investment. So we start with supported bent leg raises. We all know the progressions. You move out to straight leg raise. But the key here is as you go from straight leg raise to unsupported bilateral leg raise, that's a huge jump in difficulty and challenge to the transverse abdominis. So we want to make sure that they've really mastered the lower levels with endurance and good training before we jump up to higher levels. And then once we take it down to the bottom two pictures, now you've got a much higher level of difficulty that we're throwing on that is going to carry over to the rest of our sessions. Really important concept. Why is sagittal plane stability so important? We get a double bang for our buck. We get protection at the disc and the posterior elements of the spine, and we unweight the anterior superior hip, right? So femoral acetabular impingement in our athletes, it's there, whether we see it or not, it's fairly prevalent. So if we can benefit that as well, it's double win. So the next couple of exercises we're going to talk about also have a high level of multifidus recruitment, the higher levels from any of the stabilization exercises that we would look at least from this study. So it's under 50% MVC, but it's enough to give us a good recruitment and good synchrony between the three muscles we're talking about: glutes, transverse abdominis, and multifidus. So moving on to the bridge. It's not just doing the exercise and walking away, it's how they do it. Are they building on what you taught them previously? Can we take the transverse abdominis concept and build it into a higher level of complexity with another exercise? It's not as simple as it looks, right? So Kevin Wook was talking about the dynamic levels of doing the bridge on a ball and throwing eccentrics in. If you haven't done this work first and you haven't taught them how to control their sagittal plane stability, you probably shouldn't be doing that level of work, whether it's your ACL patients or any other patients. We know how important the core is to all the structures, and that's what we've talked about here a lot today. So the guy on the left is overusing his paraspinals. He's got maximal recruitment from his paraspinals. Transverse abdominis probably not really working much. It's being overpowered by the paraspinals, and as a result, the glutes are not doing what they need to do. He doesn't have full hip extension. The girl on the right has hip hyperextension. She's got great glute activation. She's got a neutral spine, so transverse abdominis working very well with the glutes, and in this case, a nice level spine. So the multifidus is working well in there too. So the bird dog exercise, we will spend 8, 9, 10 sessions. We will have this as sort of the theme of every session going forward. We always prime the transverse abdominis with the stabilizer, and then we jump into this exercise as well as the single leg bridging, because you get so much out of a single exercise, and there's so much complexity to this that you can give it as a home program and progress the patient really, really well with this one exercise. So we start off by trying to develop this idea of a bridge, right? So even with it in quadruped all fours, you want to get the idea that the abdominal muscles form a truss, and the spine is a bridge. So that truss supports a neutral spine. And I'll put my hand on top of the spine and I'll compress the spine down. And I'll say, use those stomach muscles, that truss that we've talked about, to press up into my hand. And they get the idea that the abdominal muscles have to contract to create that stable sagittal plane in a more difficult position than being in supine. And then we build on a level of difficulty by getting the multifidus to kick in, right? So then we raise the left leg in this case, and without hyperextending at the hip, without hyperextending at the glutes, we're just looking for a level spine. So I say, imagine you have a level across your tailbone. The left hip doesn't go higher than the right hip, right? It starts to drive them crazy. I can't see it. I don't understand it. Can I have a mirror? How am I going to do this at home? Think through your body. That's what this is about. This is neuromuscular re-education. It's proprioceptive training. It's teaching them to be more aware of their body. So you have to put a lot of tactile cueing in at this phase. And then how do we develop more levels of complexity with this? As we move the hand further away from the knee, in the picture on the right, the hand goes further along the golf club. That truss mechanism has to work harder. The abdominal muscles have to work harder to stabilize that spine. And then you bring your hand more in line with the opposite knee, so more in line with the golf club in the picture on the right. I apologize. Now you have a really good rotational challenge. So multifidus muscle has to work really hard to fight the inclination for the body to fall over. Throw some ankle weights on, handheld weights, and you have a great progression through this chain. So higher levels of difficulty. So two things I'm looking for in this exercise. One, is frontal plane stability. I don't want the hips pushing way out to the side as they do this. You can hang on your ligaments and you can hang here for 10 minutes if you wanted to, but you're trying to create a stable structure. So I tell them, imagine you have a steel rod coming from your heels out the top of your head. Line up your pelvis and your spine on that steel rod, and don't let your spine bend and break to the side. It's a very high level activity. It's very hard for people to get through. The other thing I want to do with this is I want to make sure that people are using their serratus anterior. If serratus anterior is not coming in, the shoulders collapse, there's no way you're going to get transverse abdominis and the whole core system to work, to be stable throughout this activity. And once you have a stable structure and they get that idea, now you throw levels of mobility and more difficulty onto this. Lateral plank progressions are excellent for hip abduction strength. Make sure when they're doing this that you're also going back. Tactile stimulation. Are they hyperextending their spine as soon as they change positions? That's not going to be good for when they get up and start throwing or hitting. So we want to make sure that every progression we're going back to the basics and adding on. So once we have that, now we're somewhere around week 6, 8, right? Or 4, 5, 6, 8, somewhere around there, they're starting to work back into their sports progression. So that sports progression, if they're ready for it, if they've mastered control of their core muscles, we want to work with hip dissociation. So we'll use the overhead athlete as an example. The driving leg, we've got to make sure that the glutes are able to fire and stabilize through the leg, but more importantly, we want to make sure that the hip has the ability to rotate without dragging the spine with it, without having to excessively move through the spine to make up for lack of hip mobility or recruitment. So we break that down. We work through hip rotation patterns. You can take it onto higher levels of difficulty by bringing the resistance out through the upper chain, and then finally you can make it into more sport-specific type activity. And when we're looking at the lead leg, any rotational athlete, overhead athlete, throwing athlete, the lead leg is going to see high eccentric loads from the hamstrings up through the glutes into those posterior lumbar muscles and thoracic muscles. So we want to make sure we're training it appropriately with the Russian deadlift type kind of sequencing, then adding some resistance to it, and then taking it on to higher levels for functional return to function, and developing what we just took, building it into a good concentric strength, putting power out through the upper extremities. So the cable column is the most versatile piece of equipment in the gym. It's wonderful. You can spend a ton of time on it with progressions. We start from high to low, biasing the abdominal muscles. We go from low to high, and when you go low to high, you're putting a lot more stress on the lumbar paraspinals, those multifidus muscles, and putting them involved with the glutes, and now you're taking it into the upper extremities. You've got the inferior traps and the lats starting to do their work, and we're always going back to alignment of the pelvis, alignment of the shoulders, sagittal alignment across the lumbosacral and lumbothoracic spine. So we have a great setup, a great progression. Again, back to the basics, taking it out to one arm. Finally, standing on a single leg, so that in this exercise is actually a very high level of challenge to your back extensors. It requires good glute control, good hip abductor control, but as well, really good multifidus, inferior trap, and lat control. So it's a great progression to take into with your athletes. Higher levels of difficulty, challenging the lower back more and more once you have those basic guidelines out of the way. And then finally, looking at functional flexibility. So if we don't have hip range of motion, we're in trouble at our lower back. So we want to make sure that we're looking at the posterior, anterior, lateral, thigh, and hip. Most importantly, hip rotation, especially internal rotation. We know that loss of internal rotation in the hip leads to back problems down the road in our rotation athletes. So the take home, the science of what we do, you have to keep in mind the healing sequence at the disc level, right? It's anywhere from 5, 6, 7, 8 weeks that disc is healing, the annulus is healing, that we know from our studies, and depends on how aggressive the surgery was there. So we're respecting that time frame in the early phase as we start to develop transverse abdominis and multifidus strengthening. We also want to attack those local morphologic changes at the multifidus muscles and start getting those activated, reactivated. And the art of what we do is evaluating the patient or the athlete. right? So are they stable or are they lax? We're going to have to spend more time on stability in patients that are lax. What is their neuromotor learning capability? This is all about neuromuscular re-education. How good are they at that? What do they bring to the table? And finally, we do not progress unless they have the foundations. Always make sure you're adding on and going back and rechecking, making sure that they have that stability to move on to higher levels before you release them back onto the ice or the field or whatever sport they're going to be going back to. So, thank you very much.
We have time for some questions. One announcement, someone left their phone in the bathroom. So if they don't pick it up, I'll leave it in security. Questions for Mike? Yep.
Mike, that was an outstanding lecture.
Thank you, Tim.
With the recent evidence you presented on the multifidus and fatty infiltration and the importance of the multifidus, why do you think that the orthopedic surgeons that are doing microdiscectomy do not repair that back to the bone? They just lay it there. Could that be one of the reasons that they're getting multifidus insufficiency and fatty infiltration? Because when I talked to some of the Lateral guys back in the day, they wouldn't sew it back to the bone when they reflected it to take down the I think that's the bars. Any thoughts on that? And have you talked to any spine surgeons recently? And do you think that we can do a better job at a rehab if we have a firm origin to torque?
Yeah, that's a great question, Tim, because many of the studies, especially the meta-analyses, go all the way back to the 1970s and 1980s. It's a very different surgical procedure. Back then, the open procedure, like you said, you would fillet open the multifidus, lay it aside, go do your work, and get out. So what they do now, the microdiscectomy, is a tube that goes in and they spread and separate the muscle. So there's very little actual muscle pulling off of bone. It's more going through the layers, but very little insult to the muscles. So they get in on the annulus with a very narrow scope and range. So theoretically, there's no damage to the multifidus when they go in and do the surgery. So it's probably some sort of denervation that's going on from either the pain, the herniation, or something that's happening locally. And like I said, the multifidus atrophy and the fatty infiltration, it's very localized, and it's very localized to the area of the injury or the surgery.
Any other questions? Yeah, Josh?
With rotator cuff pathology with fatty infiltration, there's some arguments that fatty infiltration never fully goes away. You're just kind of changing the ratio from the muscle bulk to that fatty infiltration. Is there any evidence that that's occurring with the multifidus at all?
So that's a great question. Actually, that's why I think it's less important to look at atrophy if you're going to study this, and more important to look at the morphologic changes, which is the fatty infiltration. Because if you look at atrophy, you can be fooled because the mass of the muscle, if you're using ultrasound, the mass of the muscle may be the same, but now it's got a 20% component of fat. So that's a great question. And we talk about this a lot. Can we change fatty infiltration? Is there any way to do it? Is it possible that getting electric stim on these guys earlier and getting that muscle firing sooner before you can really actively push them along and get good tetany at the muscle, we can make a change? I believe there is. If you look at the spinal cord literature, they have shown improvement in fatty infiltration after an 8-week program of applying electric stim and strengthening in spinal cord patients to the lower extremity, and you see a changeover from fatty infiltration to lean mass. But in the shoulder, as you repair that rotator cuff, depending on how well it heals, you may not see solid tension in there. So I think it's a different animal.
Any other questions? I have one question, Mike. You pointed out the importance of hip internal rotation range of motion. How do you work on improving that range of motion? Do you do stretching type of exercises, or do you do motor control type of exercises to improve hip internal rotation?
It's a great question. So many of our athletes, we now that we're so aware of FAI, we're always looking for an articular component to any loss of motion at the hip. So it may be somebody that we want to mobilize. They may have some capsular adhesions in there or some capsular tightness. So we may use mobilization techniques. I definitely use range of motion, but in my book, Range of motion is useless unless you're teaching them how to use the motion. So you have to follow it up with, that's why I went into detail on the hip dissociation and getting the glutes activated as you're making this transition into higher levels of activity. Because giving them range of motion without the ability to control it is setting them up for failure.